Hi, welcome to Iron Health Talk with Dr. Akram. I am Akram. In this program, we'll be talking about all kinds of different issues, health issues with different experts in the field. But today, we're going to talk about joint pain. So sit back, relax, and enjoy your time with us. Joint pain is a very common problem with many possible causes, but it usually results of an injury or arthritis. Often it is transient and resolves on its own. However, when it persists, X-rays or more advanced imaging can help make correct diagnosis. Arthritis is a common condition that causes pain and inflammation in a joint. In the UK, more than 10 million people have arthritis or other similar conditions that affect the joints. Arthritis affects people of all ages, including children. We all know painkillers, physical therapy, and surgery relieve most of the joint pain, but we need to be aware of modern aspects of medicine too. The improvement in radiology imaging to treat various ailments without knife is new aspects of medicine which we would like to talk about. Radiology has been around for over a century. It all started when Wilhelm Conrad Röntgen discovered X-ray in 1895. Since then, radiology has evolved with modern technology into computer tomography, or we call it CT, or magnetic resonant imaging, MRI, and of course, ultrasound-guided techniques. Interventional radiology therapies for joint pain include intra-articular injection, neurotomy and neuromodulation techniques, as well as transcatheter intra-arterial therapies. These therapies aim to control pain and inflammation, improve mobility and function, whilst the novel cell-based therapies have the potential for delay to surgery. Let's welcome our special guests on the show to learn what radiology has on store for joint pain, how they can help us with the debilitating condition, and much more. Let's welcome Dr. Udara Kularatna, who is a consultant in radiology in a university hospital in Midlands. And also, let's welcome Mr. Mohammed Habad, who is a radiographer, and of course, he's a medical student as well. Guys, Dr. Udara Kularatna, Udara, how are you doing today? Thank you very much for coming into our show.
I'm very happy to be here.
And Mohammed,
Thank you very much for having me.
it's nice to have you here.
Yes, it's very good.
And you are sitting in the right place in front of my
Yes,
Iron Man.
I've got Iron Man, the bones.
Excellent. Right. Okay. Let's talk a little bit about you guys first. Okay, Udara. Well, you've been an engineer for 4 years. Now you are a radiologist. How come this jump?
Yes, I'm a consultant radiologist with a special interest in the musculoskeletal system. As children, we all had dreams about what we want to do when we grow up. When I was little, I wanted to become a doctor, but I liked maths in school and ended up studying engineering in university. Then I worked in industry for a few years.
Where did you go to university? Sorry, I was about to interrupt you because you went to a special place in university, isn't it?
I studied engineering at Monash University in Australia. And when I went to med school, I went to Cambridge University as a mature student.
Excellent. Why radiology? What was the interest in radiology?
Radiology is about solving puzzles with using medical imaging. And I liked anatomy as a medical student. And radiology combined these two interests of mine. And that's why I naturally gravitated towards radiology.
Oh, thank you very much, Udara. It's amazing. I think we were expecting you in our show, but unfortunately you couldn't be here for some reason. But Mohammed, let's talk about you, man.
Yes.
You are a radiographer?
Yes, I'm a radiographer.
So you've been working as a radiographer for 2 years,
Yes.
that's right?
Yes.
And what made you to become a medical student? How did you do that? Tell me about you, all about these stories.
Yeah, so originally I'm from Somalia, I did a 3-year BSc at the University of Leeds in radiography. And then during my time as a radiographer, I felt that I wanted to pursue more, have a direct impact on patient care. So then I went to medicine at Anglia Ruskin. And that's where I am now.
And how did you start your medical school? Did you have to go do your special exams, or you because of your...
So I'm a graduate student, so I just had to do the common UK CAT exams, etc. And then take the interviews like everyone else.
So there is a way, even if you are a graduate student, you can always switch into medicine at any time.
There's always a way. Where there's a will, there's a way.
Excellent, guys. And it's amazing to have you both, but because you have something in common, and you are in a kind of same department.
Yes.
And you also did different things before you become, he's a doctor and you're going to be a doctor.
Hopefully.
Amazing. Okay, that's good. Udar, I will go back to you. Now let's talk about what does radiologists do? What do you guys do?
Yes, there are two main aspects to what we do. First, we use medical imaging to diagnose disease. We use X-rays, CT, MRI, and ultrasound to look inside your body and figure out if there's anything wrong. Second, we use imaging to provide treatments more accurately. We use ultrasound or CT to guide treatments to exactly where it needs to be. So we work very closely with other healthcare professionals. We work with radiographers, physiotherapists, GPs, surgeons, rheumatologists, and help them diagnose what's wrong with their patients and provide image-guided treatments when necessary.
It's not the radiologist, not more X-rays, isn't it, anymore? So you guys do lots more in these days, isn't it? I think it's in the general term, people, when you think about radiology, they think about X-ray. The old X-ray, you go there, they put you under a machine and they get bang, and they get a chest X-ray or something like that. It's not anymore, isn't it? What else do you do about it?
Exactly. Sorry, was that question for Mohammed or myself?
No, it's for you. I'm asking.
Thank you. Today we are very lucky. We have a very fancy kit. We have computer tomography, CT, MRI, ultrasound. You'll be amazed what kind of pictures they can produce of the inside of our body. We can create 3D imaging, and all this helps to diagnose diseases and treat diseases far, far better than we used to be able to just with X-ray 100 years ago.
Excellent. Mohammed, let me go back to you, man.
Yes.
Okay, tell me, what is a radiographer? We heard about a radiologist now. You are a radiographer now,
Yes.
right?
So a radiographer works in tandem with radiologists, hand in hand, but our job primarily is to produce the images. So your GP has sent you and you've got some back pain. And what we need to do is take an X-ray of your back. So we use a lot of anatomy, hands-on, and we put you in the correct positions to produce the correct images to allow the doctors to do what they do.
So do you guys in your radiographer school,
yes,
do you learn about this anatomy and all these things?
So it's a 3-year degree, and throughout the 3 years you have anatomy exams, you go to the cadaver labs, you do really in-depth anatomy teaching, physiology, physics as well, a lot of physics.
So do you guys have to pay for the university, or you get paid for that?
So luckily when I went to university a long time ago, the radiography degree was paid by the NHS, so I came out with no debt. Currently students that go have to pay, but also get a £5,000 bursary. So
bursary as well.
It's a very good option.
It's a very good option, isn't it?
Yeah.
So in case you are ready for medicine, and in case you are very hesitant and thinking, what can I do? It's a good course to go for radiography, isn't it? Mm-hmm. But anyway, this is a live program, so you can call us on 0203 515 5788 if you have any questions or suggestions, or write to us healthtalk@intv.co.uk, or you can also follow us on Twitter and Facebook, and Iron Health Talk with Dr. Akram. And of course, if you haven't subscribed to our dedicated YouTube channel, Health Talk with Dr. Akram, please don't forget, there are lots of things there. All right, and let's follow our program. Today we're going to talk more about joint pain and how we're going to tackle this joint pain with radiology. We have two specialists, and Dr. Udara Kularatna, he is a radiologist, and Mohammed, he is a radiographer. So they're going to bring their expertise into the show, and of course you can bring your questions forward. Okay, let's go back to Udara. Udara, let's talk about musculoskeletal radiology. It's a big name. Okay.
I know it's a mouthful, isn't it? At this point, I must shout out to my radiographer friends, as Mohammed is as well, because my job will be impossible without their help and their support. So we are like lock and key. We work together. And it's all about teamwork, and it's great to have a radiographer colleague in this program as well. Musculoskeletal radiology, we use medical imaging to look at bones, joints, and muscles in our body to figure out what's causing symptoms. We help diagnose and treat sports injuries, back pain, aches and pains in muscles and joints, and other very common conditions that a lot of us suffer from. And I think musculoskeletal radiology, this is my personal view, musculoskeletal radiology is the most exciting branch of radiology.
Excellent. That's amazing. It's I think for a lot of people, it's a kind of new thing, isn't it? And this is something is it a new emerging medicine, or is it been there for a while, or how long
it's been there? It's been there for a very long time. I mean, you mentioned how X-rays came into being. The very first X-ray was of a hand of the person who invented X-rays was Wilhelm Röntgen. He X-rayed his wife's hand, and that was the very first X-ray. So radiology first was used to look at bones and fractures. And so musculoskeletal radiology is as old as radiology itself. And today we have far more powerful tools to help diagnose and treat the problems our patients have.
That's amazing. And I know I have seen some of your 3D imaging. That looks like our Iron Man, isn't it?
Yeah.
It's exactly, you could see all the structures in a 3D fashion. That's really amazing. Okay, let's talk a little bit about joint pain. What can you guys do for joint pain as a radiologist? Usually they go to the surgeon for.
Yes. So as you know, joint pain has many causes. Either injury or arthritis, and most cases of joint pain does not need imaging. Only in selected cases, when your doctor wants to figure out exactly what's going on and conservative therapy has failed to give pain relief or symptom relief, that's when radiology helps to figure out what else is going on. Obviously, if you had an injury and you had a fracture, then an X-ray will help diagnose the fracture and also how bad it is, whether it's displaced or not. But there are other things surrounding a joint. There are lots of soft tissue structures like ligaments, tendons, muscles. If a problem with them is suspected, then something like an ultrasound scan or MRI scan can help to diagnose what's going on.
Okay, when we suspect one of those symptoms you said, can a patient come to you guys straight away, or they have to go through any other channel? Do they have to go through somewhere?
In the UK, the first port of call is your GP. So normally joint pain, thankfully, bone and joint pain, the most common variety of it usually goes away with conservative treatment that you can do yourself, like over-the-counter medication, resting, ice packs, heat treatment. If that doesn't work, you can go to your GP, and the GP will examine you, take a good history, and then either give you some medication or ask you to do some exercises or some physical therapy. And if those things fail and your GP suspects further problems with your joints or soft tissues around the joints, then your GP might refer you for imaging. So that's the normal pathway for someone with joint or back pain.
So we treat back pain in radiology. What are some causes of back pain, generic causes, in your practice, Dr. Odara?
Yes, so back pain is extremely common. So 1 in 4 of us will get it at some time of our lives. And it's the most common variety of back pain is due to ligament or muscle sprains. And this is the type of back pain that can go away in 6 weeks or so with conservative treatment. But if the pain doesn't go away, you have neurological symptoms like you have pins and needles, or you have difficulty standing up, difficulty moving. That's when we suspect other things, like, for example, whether there's a slipped disc irritating a nerve, whether there's infection going on rarely. So that's when medical imaging can help to figure out what's going on.
Okay.
I think that's what we usually, isn't it? When they have a back pain, people worry about, is it, oh my, it's a slip disc.
Yeah.
They worry about it. How common is a slip disc, Udara?
It's not very common. Usually about 4% of people presenting with low back pain will have disc-related pathology. So it's not very common.
Okay. Okay. And you spoke about some symptoms there of back pain, but what are the worrying symptoms that people should look out for?
Yes, Mohammed. So if you have back pain and several other symptoms that you need to be aware of are, if you have back pain with these symptoms, then you need to see a doctor. For example, if you have difficulty passing urine or loss of bladder or bowel control, if you have numbness or tingling in your genitals or buttock area, if you have loss of power in your legs, or if you have pain that runs down the back of both legs, if you're feeling unwell with the back pain, you have fever and night sweats that wakes you up at night, or you have weight loss and loss of appetite. And we call these red flag symptoms. These are rare, but you should contact a doctor if you experience these symptoms with back pain.
Okay.
So how urgent is that, Udara? Do they have to call an ambulance, or they have to they have time to go through the GP?
Yes, I think depending on how soon they come on. So if you have a sudden loss of bladder and bowel control, or sudden weakness of both legs, or tingling down both legs, then you can first try contacting your GP, or you can call 111 and they can advise you, or you can go online, and they might even advise you to go to A&E, because you want to make sure there's nothing serious that's causing those symptoms.
While we're talking, let's get ready with a video as well. It's mostly how we can treat back pain in such a way. Until we get ready, we keep talking about it. This video is kindly provided by OACM Orthopedics, and you could always go and watch this on YouTube if you want to see more. Anyway, thank you for that. Let's go and watch the video.
Facet injections, also referred to as facet blocks, are non-surgical treatments that use medication to relieve pain and inflammation in the facet joints of the spine. Facet injections are also used for diagnostic purposes to determine the source of pain. Except for the first two, a pair of stabilizing facet joints connect each of the bones in the spine. The bones are called vertebrae. The facet joints allow spine motion. Facet joint pain can be caused by a variety of spine conditions, such as arthritis and other degenerative disorders. Depending on the location of the affected facet joint, pain can spread to the neck, low back, and buttocks. You may be a candidate for facet injections if you have spine-related pain that is not relieved by conservative treatments. Facet injections are outpatient procedures. To begin, the injection site is sterilized and numbed. Your doctor will use a live x-ray to guide the injection needle to the facet joint capsule, and the pain-relieving medication is delivered. You will be able to walk immediately following the procedure, but should take it easy for the next few days. If facet joint injections are successful for you, the procedure can be repeated.
Thanks a lot, OACM Orthopedics, for that amazing video. It's on YouTube. Anyone won't have
Facet
a
injections,
look, you can
also
have a look.
referred to
Anyway,
as facet blocks,
let's continue with
are
our
non-surgical
talk.
treatments that use
What's
medication
it,
to
Mohammed,
relieve
we were
pain
talking about?
and inflammation in the facet
Dr.
joints
Odara,
of
you
the
spoke
spine.
about previously about how we
Facet
don't
injections
really
are also
do
used
many
for diagnostic
X-rays and
purposes to
investigations for
determine the
back
source
pain.
of pain.
How do we diagnose back
Except
pain?
for the first two, a pair of stabilizing
Yes.
facet
So,
joints connect each of the
you're
bones in
absolutely
the
right,
spine. The bones are called
Mohammed.
vertebrae.
The most common type
The
of
facet
back
joints
pain, which
allow
is caused
spine
by
motion.
muscles and ligament sprains, doesn't show up on any form of imaging. X-rays also are not particularly useful with back pain unless you suspect a fracture in someone with weak bones, such as an elderly person with osteoporosis who has back pain. Then X-ray will be helpful to figure out if that's a fracture. If a slipped disc is suspected, an MRI scan will be very useful to demonstrate that. And less than 1% of low back pain has a serious cause like infection or even cancer. And this can be picked up with MRI scan.
Okay.
Thank you very much. Anyway, we are talking about joint pain, but we are talking more about the radiological aspects of how we can treat it radiologically rather than knife. But we're going to go for a quick short break, and after short break, we'll be talking more about joint pain. Especially, we're going to concentrate on the knees and hips. And by the time we're going to join a caller as well, just before we go to the break. And during the break, we'll talk to the caller and we'll come back. Hello, sir. Welcome to the talk.
Hi, yes, I'm holding the line to talk to the doctor, please, if possible.
Thank you very much. We're going to go for the break, but you could put your question forward, but we'll go through it, and during the break, we'll analyze and come back to you. Is that all right?
Yeah, that's fine. I have knee arthritis.
What's your name, sir? Where are you calling from?
From High Wycombe.
High Wycombe, excellent. What's your name?
Sirimavan Chamind.
Oh, Chamind is all right. Okay. Thank you very much for calling. Sorry, I couldn't get your first name.
Sirimavan, Siri. You can call me Siri.
Siri, thank you very much for calling. Okay, go ahead with your question, please.
So I have bad arthritis in my knees. So my doctor gives me steroid injections, but the problem is the effects wear off very quickly. So I want to know how many steroid injections I can get, because my doctor seems to also does not know. He sometimes says 3 weeks, he sometimes says 3 months and 4 weeks. So want to know how often I can get the injections.
Thank you very much for that call, Siri. Where do you have arthritis, just to make it a bit clear?
In my knees.
On your knees, yeah?
Both
okay.
knees.
Okay, Udara, this is Siri calling, and he's got arthritis on his knees, and he's on steroid injection. Probably you heard the question, and he has had many times, and he wants to know how effective or how long will it last.
Yes, thank you, Siri, for your excellent question. You're absolutely right. So when you have pain with your knee, your doctor will give you, if other forms of treatment have not worked or have not helped, a steroid injection is one way of controlling the pain. Now, normally, we only give steroid injections either 2 or 3 times per year, because if if the knee pain goes away for long enough, for example, if it goes away for 6 months, then it's worthwhile having another injection because that can delay any eventual surgery that you might need. But if the injection only takes your pain away for 3 weeks, for example, then having another injection is unlikely to have a long-lasting effect. So that's probably why your doctor is reluctant to give you injections more often.
Thank you, doctor. Doctor, can I ask another question, please?
Yeah, please
Certainly,
go ahead.
Siri.
Yes.
So, doctor, I am from High Wycombe. So I just want to know, can these steroid injections hurt? I mean, damage my knee joint?
That's
Correct.
a very good question, isn't it, Udara? He wants to know whether steroid injection repeatedly given into the knees, will it destroy the knee?
Absolutely. So what we have to remember is any medication, if we take it too much, can be bad for us. So that's why we do not give steroid injections more than 2 or 3 times a year. So you're absolutely right. We have to be careful. Too much of steroid can be harmful as well. That's why we need to balance the benefit you get from the risk of causing further damage, and that's why we limit the number of times that you can get an injection.
Thank you, doctor. Very helpful. Thank you for helping poor Siri Mavan Chaminda.
Siri, before you go, are you happy with the answer?
Yes, that doctor.
And thank you very much, Siri. I want to tell you, this video will be uploaded into YouTube, Health Talk with Dr. Akram. Keep an eye on it, and you can always comment there. And if you have anything further, we will always come back to you on the comment section under the video. And you can be anonymous if you want, and we will try to help you out throughout.
Thank you very much, doctor.
All right. Thank you very much. Aspects of it, how we can treat it with novel treatment radiology. And our special guest, Dr. Udara Kuloratna, he has joined us via Skype. And Mohammed Habad is an radiographer and, of course, a medical student. He's here with us with the expertise. Mohammed, let's talk a little bit about this role of radiology back pain. What do you guys do with this?
Yeah. So as a radiographer, we can help the radiologist treat back pain. So this can be in the form of CT-guided procedures or even fluoroscopic procedures. So as the radiographer, what you're providing is live imaging to the radiologist so they can pinpoint exactly where they need to go. This makes treatment more effective for the patient and has a higher success rate than simply trying to use anatomy to guide the procedure.
Rather than going blindly.
Rather than going blind, you have an aeroplane.
And that's what we showed in the video as well, isn't it? We had that animation video. Exactly, they were pinpointing that place where you have that particular pain, and they go and treat it. They inject this.
So they can find a specific nerve root, for example.
Nerve root.
And help.
Okay, there is a caller joining with us. Hello.
Good evening, sir. How are you, sir?
Good evening. Thank you very much. What's your name, sir?
Shafiqul Alam Shafiq calling from Burnley. I'm happily...
Shafiq, where are you calling from?
Burnley, Lancashire.
Burnley, excellent. Thank you very much. Go ahead with your question, please, Shafiq. I think we missed the caller. Udara, let's go back and talk a little bit about radiology and back pain.
Certainly. Specifically, the treatments that we do, as Mohammed said, we do the guided injections under either CT or fluoroscopy, and that's where the expertise of our radiographer colleagues help us. The patient usually, as you saw on the video, the patient usually lies face down on the examination table, and we give local anesthetic to numb the skin. Then we'll use the imaging to guide the needle tip to a position near the nerve root that is being irritated by a bulging disc or a slip disc. A mixture of steroid and local anesthetic is then injected around the nerve root, and it's a very straightforward and safe procedure when done at a specialist center by trained professionals with the help of our expert radiography colleagues as well.
So these procedures you could do by CT guided, is that right? Computer tomography or MRI? Is it MRI or what else you do?
Normally, we usually do them under CT or fluoroscopy. I personally do them under CT,
okay,
but there are many doctors who do it under fluoroscopy as well.
Okay, can you explain a little bit about this fluoroscopy? I don't think many people know about fluoroscopy.
Exactly. It's exactly the same as a normal X-ray. With a normal X-ray, you just have a snapshot of your chest or your hand or your knee. But with fluoroscopy, you can get continuous images. So, for example, if you're inserting a needle into, say, a joint under fluoroscopy, you can actually see the needle going in. So it's almost like X-ray vision, basically, looking into someone's.
I think you are telling like it's a normal camera. You take a snapshot, and a video camera you take a whole the process. Yeah, it's something similar.
Absolutely, it's like a live video camera. Seeing through your body.
But
Absolutely.
see through your body, that's amazing, isn't it? That's really interesting, Udar. I think it probably will be really useful for our viewers who are there and who has this kind of conditions, and for them to know what we could do more for their problems, isn't it? Okay,
Absolutely.
let's go ahead and we talk a little bit about hips and knees. A lot of people have hip knee pain. Mohammed, you would have seen a lot of people coming to you guys with hip knee pain and they want x-rays and stuff.
Yeah. So we have a lot of patients that come in with knee pain and hip pain, generally due to osteoarthritis. And then we provide generally standard x-rays, AP and lateral, which means the front of your knee and the side of your knee. This allows your radiologists and surgeons to have a look to see if your knee is in good condition or not.
Okay, Udara, what you guys do? What can you do more for this joint pain rather than plain X-rays? Are there any novel treatments these days?
Exactly. First, I think X-rays play a role in diagnosis, as Mohammed said, of osteoarthritis. But as we discussed earlier, there are a lot more structures around the hip, like ligaments, tendons, muscles. And within the joint itself, there are cartilaginous structures which keep the joint together. So problems with these are seen in MRI. So MRIs can tell you if there are muscle problems around the hip joint or ligament or tendon problems, and that gives us the answer about what's going on, what's causing the hip pain. Much more information than an X-ray would. And in terms of treatment, again, your doctor will prescribe first conservative measures like oral analgesics, an exercise program, and if they fail, then they might suggest an injection into the joint, and this can work in two ways. The injection first will give you pain relief, symptom relief, and if the injection gives you pain relief, then we know where exactly the pain is coming from because it was a targeted injection under image guidance. So if down the line a surgeon wanted to do something about it, then their confidence increases as to where exactly the pain is coming from because the injection works as a diagnostic procedure as well.
To make it short, I think X-rays shows the bones, is right? Yeah. And the MRI is more for the soft tissues like muscles, tendons. Is that right? Can you explain a little bit more about the MRI? What does it do?
Absolutely. So MRI uses a mechanism where the MRI is a huge magnet, and it picks up different signals from different tissues in our bodies, and it depends on the water content of different structures in our bodies. And because different structures like muscles, tendons, and bone have different water content, the MRI will show these structures clearly and separate from each other. And that's why MRI is able to show these structures very clearly for us to identify any problems with them.
Right, so that explains more about the injections you do, because when you do under MRI guidance, you could see those structures, not the bones, which is around the tendons and all these things. And of course, you could target them and inject them, isn't it?
Exactly. Normally, MRI is used for diagnosis, whereas for treatments, we use ultrasound or we use CT because, as you know, MRI is a big magnet. So we don't want to go near it with metal needles.
Oh, yes, of course.
So the treatment is given with either X-ray, CT, or ultrasound. But there are some MR-compatible needles now coming to the market, and sometimes they can be used to guide needles under MR. But that's not common practice in the UK at the moment.
In the UK at the moment. But of course, yeah, that's good. That's good. So what can you do for example, for knee pain? Do they do more than injections, or what else can you do?
Yes, so there are different types of substances that you can inject into the knee other than steroids or anesthetic. For example, hyaluronic acid, or there are various types of chemical substances that can be injected. But we have to say there's very little evidence that these things work. There is anecdotal evidence that they work, but very little accepted medical evidence that they work at the moment. So steroid and anesthetic injections are at the moment used for purely pain relief, not to really as a treatment. It's for pain relief mainly.
That's true, as a treatment, isn't it? So steroid is still as a pain relief rather than the treatment, isn't it? And as our caller, I think Mr. Siri Chaminda asked earlier in the program that how many times can you inject these steroids per year, Udara? This is really important. A lot of people ask for steroid injection. They come repeatedly, and sometimes we have to refuse it, and they get angry, and they got annoyed because they don't understand this. Why can't you inject more?
Absolutely. So in our practice, we don't normally inject more than 3 times a year. And again, for them to have a repeat injection, the first injection must have given long enough pain relief. And the patients that we select for injections are people who do want to have surgery or want to delay surgery. And the reason we don't give steroid injections more often is that, as we discussed earlier, they can be harmful and cause more harm than good if given more often.
That's the point, isn't it? That's why we don't give, even though the steroid gives a good pain relief for that short period, but you can't give it for a long time. And as a radiologist, when do you think, like if you had a patient there and you keep injecting, when do you think that you are asking for help from the next level, maybe a surgeon or maybe from other department?
Yes, normally the patients who come to us are either referred by surgeons because the patient can't have surgery, for example, because of other medical conditions, or they want to delay having a knee replacement or hip replacement. They don't want to have it when they're young, so they want to delay it as much as possible. So they refer the patient to us, and if the patient has a good response, then they re-refer the patient to us for repeat injections within a reasonable time interval. But if the patient doesn't have good response to the injection, or the pain relief doesn't last long enough, then they might then go on to offer them surgery.
Are there any way that you could treat these guys, these patients, and you can like cure them, or you can send them home and they don't need surgery afterwards?
So regenerative medicine, is that what you're asking about?
Yeah, in general in radiology with these injections and stuff.
So Dr. Adara, is there a future for regenerative medicine in musculoskeletal radiology?
I think there is osteoarthritis is a huge global health burden. So there are loads of research happening around the world, particularly in America and also in the UK. There's something called the Osteoarthritis Initiative, which is funding lots of research into figuring out how we can regenerate the cartilage that's damaged in osteoarthritis. But these are, unfortunately, at present, are in an experimental stage at the moment. I'm sure in the future, when these treatments come on board, musculoskeletal radiology will play a huge role in delivering these treatments to the correct location within a joint.
You know, there is always, we think, like olden days, we didn't have many people with all these arthritic problems. Is the arthritis, is it more in these days, or is it we are living too long and we get into trouble?
I think you hit the nail on the head there, because the osteoarthritis particularly is a degenerative process, and the longer we live, the more damaged our bodies, our joints become, and that's why we see the prevalence of arthritis more and more these days, because we live longer.
Yeah, that's really interesting, Udara. Even when I was reading for this program, I have realized that even dinosaurs had arthritis, and certain dinosaurs, and our ancestors, in Egyptian, some mummies, they found arthritis as well.
Wow.
Especially gout arthritis was common in Egypt as well. So, yeah, that's very interesting. Let's go ahead and talk a little bit about.
So, Dr. Udara, so I've done many X-rays for shoulder pain and frozen shoulder. How does MSK radiology come into shoulder pain?
Yes. So if you talk about the causes of shoulder pain as well, shoulder pain that comes without injury can be due to several causes. So pain and stiffness that lasts for several months may be due to frozen shoulder, a process where the joint capsule becomes too tight, so any movement becomes painful. Or pain that gets worse while you're using your shoulder could be due to impingement. Impingement is when a tendon in your shoulder rubs against bones or other soft tissue structures around it. And if there's sudden severe pain or locking after an injury, that may be due to a ruptured tendon or a dislocated shoulder. So how does radiology help? So, of course, if you have an injury and the shoulder locks and dislocated shoulder is suspected, an X-ray can help to show that. But if there is any soft tissue problems, for example, if you're suspecting a tendon tear around the shoulder, an ultrasound scan can help to identify which tendon is torn, how badly it's torn. And if you're suspecting frozen shoulder, then MRI scan helps to figure out what's going on. MRI scan is kind of the gold standard for shoulder pathology, but because it can show both soft tissue problems and bony problems that may be causing pain.
Shoulder problems are quite common, isn't it?
Very common.
Is it more to younger people, shoulder problem, than the knee and hip problems are to the elderly crowd?
I think we have two separate cohorts. We have people who are very active, for example, cricketers or tennis players or people who use their arms very well, like painters and decorators. They get shoulder pain, shoulder symptoms due to overuse sometimes. So repetitive minor injury over a long period of time can cause damage to ligaments and tendons around the shoulder. That's one end of the spectrum. The other is, as we discussed earlier, degenerative change. So the shoulder joint itself can become osteoarthritic. There are other joints around the shoulder, like the acromioclavicular joint, that can become osteoarthritic, and that can cause pain. So we have these two peaks almost of presentations with shoulder symptoms.
That's quite interesting, and we do lots of shoulder arthroscopies. Moment, I think you would have seen in theaters, in orthopedics, and we put this cameras and have a look and a washout, and then sometimes they treat it as well. As a radiologist, do you do injections to shoulder, or do you do anything more? Radiologist, Sudhara?
Absolutely. So for example, if you take frozen shoulder, we do injections under ultrasound guidance to treat it. And if you have any other problems, for example, if you have bursitis, if you have acromioclavicular joint problems, again, these are all amenable to image-guided injections. And I must say, the vast majority of these injections are done blindly by your GPs or rheumatologists, and they work really well. And in the rare instances where they don't work if done blindly, that's when they are referred to radiology for the injection to be done under image guidance.
So yeah, I think as you say, it's what when you guys do is quite accurate, isn't it? You know where you're going, and you see with ultrasound or other imaging. That's right. Let's summarize a bit, Tudar. Like I want to give our viewers a small summary of what we did today, what we talked today. So in case this condition come, they can go to help for the next level where the GP, and they could wait and see what the GP says about it, and the correct path to go ahead to reach you guys or the surgeon.
Exactly. So the first port of call, actually, you start with treatments that you do yourself, for example, hot and cold packs, oral analgesia. And then if that doesn't work, you go to your GP, and then the GP might refer you to specialist treatment, either a musculoskeletal interface clinic or a surgeon, a rheumatologist, or a physiotherapist to help with your symptoms. And sometimes if your symptoms are bad enough, for example, you can't move your joint at all, or you have fever with it, or if it's a knee, for example, you can't put weight on it, or you feel unstable and the knee gives way, then you shouldn't wait. Then you should seek medical help sooner rather than waiting for it to get better, because there may be some underlying issues that need treatment quickly.
Of course, we can't forget about the infections as well, isn't it? It's not only we talk about arthritis, because these joints get infections as well.
Just like any body part.
Yeah.
Absolutely. They are rare, but that's why it's important if the joint is hot, red, and swollen, and it's usually it's one joint that is affected, and you have fever with it, that's when we suspect, and particularly in patients with diabetes. Or someone who has had an injection into the joint previously, and then it has swollen up and is red and hot and painful, that's when you suspect some infective process going on. And for example, if you have multiple joints involved, for example, multiple joints in your hand, then it may be an inflammatory process like rheumatoid arthritis. And then your treatment pathway is slightly different. You'll be referred to rheumatologists who will start treating you.
That's a good point what you said actually. It's just to make clear, like if it's one joint, it's red, it's painful, and then you have fever, other symptoms, and that's more likely it's an infection, and that's kind of urgency, isn't it? You can't wait with it for too long. But if
correct. Correct. And also, if a red hot joint can also be due to gout. For example, if it's in your big toe, if it's a big toe that's affected, that's a very common place for gout to appear. And again, that is red, hot, very painful, and that's how gout presents. But infection also, it'll be usually one joint, red, hot, painful, and you might have fever as well.
Thank you for very much bringing gout into it. I had developed gout about a month ago, and I had gone through exactly what you said. And of course, there is a video in Health Talk with Dr. Akram YouTube all about gout you need to know.
Wow.
And we got a few more minutes left. Mohammed, can you say a few words before we wrap up this program?
Okay. So, as a radiographer, we circulate the hospital. We work in A&E, MRI, CT, and we are generally the guys behind the scenes. We're providing live imaging. We're providing all the behind-the-scenes actions to allow doctors to treat patients. So, not many people know about radiographers, but we are there, always 24/7 available to help patients and help patient care. So that's one of the things that I think, if you want to go into radiography, It's a very good career. You have there's many options. You can always move from CT to MRI, etc. You're always playing with million-pound machines, high-tech equipment. So it is a very fascinating field.
Thank you very much, Mohammed. When you become a doctor, are you going to be a radiologist or are you going to be an anesthetist?
Oh,
hard question, man.
I'll leave that one up to the viewers.
Thank you very much.
I think you'll make a brilliant radiologist.
Thank you.
Very good. Udara, what do you like to say? I mean, you've been what did you do? An electrical engineer. I said, how come you chose radiology? Okay, you got half a minute to talk about that.
Yes, I mean, radiology is the most, for me, like most technical of the medical specialties. And as I said, it deals with the anatomy, which I loved. And musculoskeletal radiology deals with sports injuries. Sports, I love sports. And all these combined to influence me to select this specialty. And every day I wake up with a smile on my face because I love it. And the cases that we see, the patients that we can help, is very diverse, and most people get better with treatments, and we help them by diagnosing what's wrong with them, because pain can be very distressing, and we help them by diagnosing what's wrong and help other clinicians by diagnosing what's wrong with their patients. So it's a very satisfying career to be in. I recommend it to anybody who's thinking about a career in radiology.
Udara, thank you very much. It's an amazing program. In short time, we have given exactly what they need to know about radiology, what radiology can do for joint pain, back pain, knee pain, whatever you name it. And Mohammed, thank you very much for your expertise on the field, and you told us from your side what you guys do. And for all of you, we talked today about joint pain and what radiology can do for us. And thank you very much, Udara, and thank you, Mohammed. Thank you all of you for being with us for this special program. This will be uploaded in the YouTube probably tonight or tomorrow. Don't miss out Health Talk with Dr. Akram YouTube, and you could go there and watch all these programs there, and you can leave your comments there, and we will come back to you and reply you. Anyway, thank you for staying with us in Iron Health Talk with Dr. Akram. If you have any further questions, please email us healthtalk@intv.co.uk, or you can message us on our dedicated YouTube channel, Health Talk with Dr. Akram, or Facebook, Instagram, Twitter. We'll come back to you as soon as possible. But don't forget, next week is really important. We're going to talk about vaccine. So if you're waiting for COVID vaccine, don't miss out next week. Okay, thank you very much. Look after yourself, guys. Thank you.